Well, good afternoon, everybody. It's Friday the 13th. Oh my, spooky 2020. Welcome to SADS Facebook Live, episode number 38. I'm so glad for those of you who are able to join us live or those of you who you will see this eventually. So whether it's a good afternoon to you, good evening, or good morning for those of you somewhere else across the globe, thanks for joining me. I'm Mike Ackerman, genetic cardiologist at Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic. I also have the privilege of serving as president of the board of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation. And so on behalf of Alice Laura, the CEO of the SADS Foundation, and her entire team, thanks for joining me. It is spooky, isn't it? Friday the 13th. I have to show you why. This is not good, people. This is from the Johns Hopkins COVID site. And every day we're setting records. We don't like to set these records. Come on. 153,000 COVID-19 cases yesterday. In this pandemic, we are now at 53 million worldwide, 1.3 million deaths. United States, 10.6 million, 242,918 tragic deaths. We added about 400 cases in Olmsted County alone since last week at 4,438. That's the bad news. The good news, there have been no deaths, so we're still at 30 deaths for a case fatality rate of best in the world at 0.67%. But that only works when a healthcare system, doesn't get overrun. Some of you are hearing the numbers. There was reported earlier this week that over 1,000 of my colleagues at Mayo Clinic, nurses, healthcare providers, staff, we are out of commission because we are either under a direct exposure quarantine or we are recovering from COVID ourselves. So if we, the healthcare providers across this land, are not there to be able to take care of you, we are not there to be able to take care of you. So we got to have our game on. I've been saying it for a long time. I mask, you mask, we all mask together. We don't need a government mandate. Let's just do it. It works. It definitely doesn't hurt. Wash your hands. My hands are getting dry as can be, but you got to. 70% alcohol, do it. Distance, come on, let's be aware of ourselves. This is not the time to be going to the bars at night, mask down, hands unwashed, touching our face, and then we wonder why we're having 150,000 cases. So that's our weekly reminder that we need to buckle up. We are in it, and it's not getting better right now. So refuse to fear, but game on. So make sure we are having our game face on and doing all the right things. Well, that's it for COVID-19 pandemic. We started in the midst of the pandemic like February. We're now 10 months, 11 months later, whatever the time frame is, and we're here for you. And our SADS families, you are so important to us. And thank you for joining us. I see some of you coming in, checking in. And so great to have you join us. Brianna, one of our great regulars, hello out there, and give a hello to your grandmother. Well, it is with a pleasure. We are in National Family Health History Month for the month of November, and I'm just delighted to have Mr. Lee Cooper from Cambridge, Massachusetts, join me today, along with one of our genetic counselors from Brigham and Women's in Massachusetts, Allison Cirino. And we're going to speak about the importance of knowing your family history, acting on your family history, and respecting that family history, both within the family and in the healthcare community when that family history gets presented to a healthcare provider. So Erin, drum roll, she's going to bring up Mr. Lee Cooper for me. And then shortly, we'll have Allison Cirino join us. So, Lee, welcome to SADS Facebook Live.
Thanks, Dr. Ackerman. I don't think I was worthy of a drum roll, but good to be here.
Yeah, but it was a good one. So Lee, you had something pretty incredible happen 4 years ago when you were 29 years old that started your SADS journey. You want to share with us all sort of what happened, why it happened, how it happened, how come it is that you look so amazingly good when it could have been so incredibly tragic 4 years ago?
Yeah, of course. Happy to. So almost exactly 4 years ago, it was December 2016. I think it was December the 18th, week before Christmas, day after my wife's birthday. We had actually just had a really fun weekend celebrating my wife's birthday, going to a company holiday party, all that kind of stuff. And actually, we were just thinking about starting to build our family and have kids. Life was good. And I went to bed. It was a Sunday night, ready for the work week ahead. And I didn't wake up Monday morning because in my sleep at about 4 a.m, I had a sudden cardiac arrest in bed. And I only know this because it's been recounted to me, and I'm lucky to be here for it to be recounted too. My wife is a light sleeper, thankfully, and she got woken up by my going through the cardiac arrest in bed next to her. And she immediately, sprang up and called 911 and performed CPR on me for many minutes, almost 10 minutes, I think, while on the call, while waiting for the medics to arrive. And luckily, we live in the Boston area. At that time, we lived in Boston proper, just down the road from Tufts Medical Center, which is a great medical center and has an arrhythmia clinic, actually, and great electrophysiologists. But I was brought to thankfully, her CPR worked and kept oxygen going to my brain, and the medics kept it going, and my heart came back. And I was in the cardiac ICU, unconscious for a couple of days, underwent a cooling protocol, completely unconscious. Really didn't, my family, my parents drove up from New York, really, they didn't know if I was going to survive. And if I did, if I would be, physically or cognitively the same person. Luckily, I did wake up and, over the course of a few days, slowly, fully regained consciousness. But as these things go, and then maybe some people listening know, it takes weeks and months and even a couple of years to fully get back sometimes all the memory that you may have lost, and vocabulary recall and all that sort of thing. But again, I was very lucky that the prognosis was unclear in those first few days and weeks, but then I quickly was getting better, and I received an implanted defibrillator, which I still have, and I take nightly Nadolol, hopefully as an effective medicine to hopefully prevent arrhythmia in the future.
Well, Lee,
yeah, that's kind of the story.
Yeah, Lee, you look fantastic. So obviously your wife performed incredibly effective CPR. And I imagine that she probably imagined or envisioned doing many things to her husband and with her husband, but probably never imagined doing CPR on her husband. How did she know how to do that?
It's a good question. She's an amazing woman, and she's very strong, and my ribs felt it for many weeks thereafter, but in the best way possible. She actually had been a lifeguard in high school. We actually lifeguarded together when we were younger, in the summertime. But she hadn't been trained in quite some time. I think the memory of that a bit, and then thankfully the 911 operator was able to walk her through, and just keep her motivated and coached her as she waited for the ambulance to arrive.
Wow. And Lee, if I can ask, was that cardiac arrest that night your first personal declaration of something being wrong with your heart?
So it's sort of a seemingly straightforward question with sort of a complex answer, as these things go, especially as we talked about during family history or family health history month. So that was my kind of entryway into being a long QT, arrhythmia patient. But there is more complexity behind it. What I mean is that, when I was a kid, I actually had experienced once what we thought was a seizure. a grand mal seizure in my sleep.
Hmm.
But it was very likely misdiagnosed. It was probably an aborted cardiac event of some sort. And I also, as a high schooler, I personally never had heart problem. I always played sports my whole life, competitively through college. So I never had an issue, the type of issue you would think of. But I did have cousins who had some cardiac issues. So I knew there was a clinical diagnosis in my family when I was in high school.
So for yourself, except for some pre-puberty, a weird nighttime grand mal seizure type spell,
Yeah,
that was your one and only spell, and then your cardiac arrest some 17
yeah.
years
I went through college again, playing sports. Never had, at least I didn't perceive having any sort of fainting or syncope I never had any problem I could speak to. No.
And do you remember if you and your family back then brought you to physicians? And I'm guessing that maybe one of those physicians may even have been a neurologist that called it a seizure?
Yeah, exactly. We thought it was a neurological event of some sort. When at that time I was like 9 years old or something like that.
Wow.
Yeah, I was young. I remember
it's kind of one of our reminders. It just so breaks my heart to see the number of long QT individuals previously misdiagnosed as epileptics, treated as epileptics, even dying as an epileptic. And I've been on a crusade to try to get our neurologists to say, please, 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 if every patient who has a generalized grand mal seizure deserves also one ECG, while you're putting the EEG on the brain, can you please give me one ECG on the heart? And so thankfully that mistake some 20 years ago, 20 years prior to your cardiac arrest, didn't turn out to be a costly mistake. But you mentioned something about family story and your cousins being diagnosed. And to sort of look into that a little bit more closely, I'd like to have Allison Cirino join us. So Allison is a genetic counselor from Brigham and Women's, and there she is. Hey, Allison.
Hello, good afternoon.
So what do you think, Allison, when you hear this kind of story of that there was a cousin? So maybe Lee, refresh us a little bit. And you actually said that not only was there a cousin with something, but that relative actually carried the diagnosis of long QT syndrome long before you did the CPR requiring event from an amazingly strong wife to save you.
Yeah, and obviously, to protect the privacy of those people, I won't go into details. But they basically, when I was in high school, I think it was two cousins even we knew at the time were basically clinically diagnosed with long QT. But I, as a high school kid, didn't know it was called long QT. I just, as a high school, I knew through my parents that there was a heart issue, in the family. And so we actually were brought into a pediatric cardiology office, and we're given EKGs and ECGs, I guess. And my measurement, my QTC at the time, I didn't know what that was at the time, was a little bit abnormal. It was kind of what they call borderline in the old report I have from that meeting, 20 years ago almost. But I was passed off as being, there was no genetic diagnosis at that time. Maybe there should have been. And I looked healthy. I played sports. They couldn't visually see why something might be wrong. And so a borderline case was kind of let go. I forgot about it for, 10, 15 years.
Wow. Allison, when you hear that story, I'm guessing that if you got $1 for every time you heard that story, you might have a good start on college 529 saving plan built up by now.
Yeah, there's some truth there for sure. But also, I do want to point out that it's actually also wonderful that you even heard about this from cousins in high school, because we know just right off the bat sometimes that milestone isn't met. All too often these types of conversations aren't happening until, after a person like yourself has had a cardiac arrest and people are starting to connect the dots. So it's great that the conversation started. But one thing that I was thinking about as you were speaking is, how challenging it can be in families to remember to keep the conversation going sometimes. And that's between family members, keeping each other updated. Did you go in for this testing? Was the result? Was there something suspicious that happened? Keeping that dialogue going, I think, can be one of the biggest challenges, like the dialogue between families and then the dialogue back and forth with healthcare providers, so that, the medical record is as up to date as possible with the goings on in the family, since sometimes that might change somebody's, perception of your risk.
Right. And Allison, in light of National Family Health History Month, and also yesterday, which we'll give a shout out to all the genetic counselors across the globe. Yesterday was, I think, Genetic Counselor We Love You Day.
Yes, Genetic Counselor Awareness Day. Yeah. So I think, more than just appreciation, though, I appreciate that. It's more to kind of shed light on this topic about how important family history, how important genetic disease is, and I think, how valuable it can be when you have a team that's trying to tackle some of these challenging issues.
And when you take a family history, Allison, like that, I've certainly been impressed how many times the details about the family story are murky at best. And you often have to send them home on home assignment or have them call up Uncle Joe or Aunt Susie right there in the office to get clarification. And
Absolutely.
What was transmitted as sudden unexplained death. I have this amazing story where they had 2 of those 3 letters right about that relative who died suddenly. The S and the D. It was a sudden death. So S was right. It was dead. The D was right. But the U was wrong. The revolver had something to do with it. So nothing unexplained about that death. And so how important, I guess the point that you probably do a lot is genetic counselors I liken to as detectives in many ways, that not to accept the first, oh, he died of a heart attack. Mm-hmm. At face value. And so what kind of things do you do when you give the family's assignment to figure out all the details about the family story?
Yeah, you're absolutely right. It very often requires additional conversations in investigation. I think many of us can probably think in our own families about whether or not there's like the go-to person that has the details. And as you alluded to, now we have the advantage that these phone calls can happen in real time in an exam room. But for, many, many years, this wasn't possible. But, we're often trying to have these conversations as a starting point, to put a structure in place, to understand what the family looks like who are all the players in the family, to try to understand, what we know already, what we need to further investigate. And then, like you said, give some homework assignments, really, like, could you try to get more information? And truthfully, a lot of times we're needing medical records. And I think that is, a big part of this, is that sometimes there's only so far you can go with the stories that are in the family when you're really trying to make risk decisions based on it. So we often are trying to assist family members with requesting medical records, helping to look it over, asking some, when we have a conversation about family history, one of our jobs is to ask like the probing questions, things that might not automatically come to people's minds, and that they might be, not unintentionally holding back or not really recalling. So that's really where it is a conversation back and forth at the initial time, and is certainly an ongoing process.
Right. So Lee, Allison, let's do a little movie exercise. I think, I'm not sure, you guys could correct me if I'm wrong. Wasn't there a movie called Sliding Doors or something that the whole scenario changed depending on the exact timing of when they, if I'm remembering it right, somebody out there in Facebook Live, correct me, but the point being how different things could have been if things would have been intercepted differently. So the exercise we'll do, knowing what you know now, Lee, and knowing how close of a call 4 years ago was, what do you wish would have happened when there was awareness of something going on in the cousins? How might that have looked differently from your perspective? And then Allison, if you had been involved, at that time, what would you have then done as well once you caught wind of that story, so that we could have made December 18th, 2016, just a fun evening a week after your wife's birthday and not so dramatic? So, Lee, let's start with you. What would you have hoped might have done differently, or you hope now would be done differently for all families out there?
Yeah, that's a great question. Three things come to mind immediately, and all of them relate to getting genetic testing. Because at the end of the day, that's the medium of information that we have, right? The most concrete information we can all act on. And so the first one is what you mentioned first, Dr. Ackerman, which was when I actually hadn't thought of it until you said it, but every pediatric case of epilepsy or seizure should also consider a cardiac panel for inherited arrhythmias. There's why doesn't every epilepsy clinic in the country do that? The cost of doing that is so small, both to the system and to the patient. So that seems like such an easy thing to do. That didn't exist when I was that young, but today, the equivalent kid today having a seizure at night and his parents being terrified, they might as well get a cardiac panel, a genetic test. So that's number one, the first thing that comes to mind. Number two is what you were then talking about, which is later when we discovered the family history, and the answer is the same thing there, right? Where there's a clinical, and when it happened to me, it happened to be at a time when genetic diagnosis was more expensive, was just getting, I think, adopted by all physicians. But today, there's really no excuse. If you learn of either a genetic or clinical family history, someone dies really young from a heart event. If a different scenario could be, you've a second cousin who died during football practice in high school, and everyone thought it was a heat stroke or something like that. And those are the sad cases we all read about today too. Right. In all those cases, there's no reason for there not to be extensive family cardiac testing. Then the final thing is later. So I wish my wife and I were both aware of preconception carrier screening and thinking about having a family. And we were going through doing that actually, even as when I had my cardiac event. But why not do it even younger? Like the same way, when everyone turns 21 or 18 or goes away to college or something like that, why not get a carrier screen that also includes maybe a panel of dominant arrhythmias in addition to recessive disorders? And so that way, as a young adult, you can go into because for example, what if I had not had my cardiac arrest before building a family? And I didn't know this risk in my kids, and my kid could have been at risk for sudden infant death without me knowing it. That would also have been devastating to me. And right. So, even before having the event, just as a person, as a citizen in this wealthy country, I should have had that genetic information for my offspring, basically. So those are the three things that come to mind. It's testing for seizures in kids, testing when there's any family event, and then testing as adults when you think you're prospectively going to have a family.
That's great, Lee. That was three incredible answers. I wish I could hire you to be on my team. Allison, if that story...
Minnesota seems nice.
As you heard it, what would you hope would happen now in 2020 and heading into 2021 with healthcare providers in general, those with or without the benefit of having a genetic counselor like you on the team? What should we expect differently, hopefully, when we hear a story like that tomorrow or Monday in clinic?
Right. Yeah, I think, Lee's hit on some really important things there. And I think one thing that stands out to me is the idea that it's maybe like the privilege and the challenge of taking care of patients with inherited disease is that it's not just the person in front of you, it's the family as a unit that you need to take care of. And so we need to prep people and give them resources and tools so that we can, to the best of our ability, try to help them communicate the message through their family. Because it's a lot of responsibility on the patient that's right in front of you in the moment to then turn around and say, now you have to share this complicated scary and potentially overwhelming information with your relatives. So I think people are coming up with, many different types of creative solutions and things, short of a provider being able to call your relatives directly. What are some resources that we can provide, and whether that's a genetic counselor, your primary care physician, anybody that you're having a conversation with, what are resources that can make that job easier for the patient? So hopefully, spread that word and make sure that the right word is being spread. Because I think, part of it is, it's so important, and your story is an example of this, to make sure people are getting whatever would be the appropriate screening for their condition, whether it's, an echocardiogram or whatever the case may be. But those terms are foreign to some people. And so we just want to make sure that the right message is making it to the families so that they can know and, turn around and hand that to their healthcare providers so that that process can start in the family. So I think that's something that any provider can and should do once a diagnosis like this is suspected in the family.
Yeah, and I know we at the SADS Foundation, and you guys can access it, have tools and resources for what to give and disperse to your relatives to sort of walk them through. And so check that out at the SADS Foundation, www.sads.org for those tools. Well, I'm going to take some questions that have been coming up, but before I let Lee, you go, and Allison go, I'm going to give you, Lee, 2 minutes or however long you take to leave the world with your final encouragement, advice, admonishment, directive. The world's your oyster, Lee. Take it.
A lot of pressure. I guess there's two things that really come to mind. Just while I have people's attention here. First is, I'm a long QT patient, and I will be for my entire life by definition, right? Because it's in my DNA. And a lot of the people watching are in the same boat, or they have family members who are in the same boat. And just remember that it's really important to not let it define you entirely, right? That it's obviously a part of you, and it can lead to difficult times and challenges, but it certainly doesn't need to define your whole life. So just everyone, any patients out there, just always keep that in mind when, there are challenges, because I'm facing one right now, actually, due to my long QT, and that's what happens. And then finally, what we've been talking about, the thing that's really important, it actually is one of the most important things to me in the whole world, is that people take seriously sharing this information with their family and their friends, just for society, and people get genetic testing. It's really readily available these days if you go to the right resources, contact SADS, contact other people, and it's really actionable, right? You can improve your care, you can prevent deaths in family members, and you can even prevent the disease itself, right? Again, I alluded to this before. It's not talked about a lot in rare disease communities, not nearly enough, because people are so focused on caring for themselves and their loved ones. But if you're aware of a genetic disease like long QT, one really viable option for a lot of families is IVF. And you can even ensure that you only implant embryos that are free from a disease like long QT or other conditions like that, so that you don't have to worry if your kid is going to die of sudden infant death potentially, or have a defibrillator his or her whole life. So diagnostics are really actionable in a lot of ways. Don't be afraid, and take agency as a patient and ask for a genetic counselor, because they can be really valuable tools.
Great.
So,
And Lee, thanks so much. Really appreciate your story. I appreciate you, and thanks for all you're doing as a advocate for our cause and for the SADS Foundation. Allison, your final for the world in the name of, GC Awareness Day yesterday, and to you and to some of my favorite GCs throughout the globe. If you're watching, Jody Ingalls in Australia, shout out to you. And of course, my own GC in our genetic heart rhythm clinic, Katie Agre. So don't do it without you guys, Allison, with what you do and the value that you bring to a genetic heart team. So thank you. But what say you, Allison?
Yeah, so I think we just will, my closing thoughts, just given the month, given the, Thanksgiving around the corner, I think just needs to focus on this idea of opening the dialogue with family members about things that are going on in your personal health history. These are not easy conversations sometimes. Sometimes people worry about burdening relatives with this type of knowledge, but this is the only way that we can really kind of harness the power of genetics, is if we're spreading the word in the family and getting the right people in to be screened and evaluated before something bad happens in a family. So have those conversations, keep them going over time, and keep your healthcare providers updated about those conversations that you have with your family members.
Great. Allison, thank you for taking your time out today and for all that you do. And Lee, we didn't have your lovely bride on with us, but would you thank her for doing what she did so the tragedy
every day
averted and that we could have this incredible conversation. So I'm sure she's special to you. She's obviously a hero to us, and to all of those first responders who've done effective CPR to save a life out there. You know who you are. Thank you. Appreciate all of you out there. So Allison, have a great weekend. Lee, you too. And give a great to your wife.
Thank you, Dr. Ackerman. Thank you, Allison.
And in our few minutes remaining, wasn't that incredible? I love that. Just to follow up a little bit on what Mr. Cooper talked about, I know people have asked about pre-implantation and genetic testing and in vitro fertilization as a way to make sure that the disease has no chance of being present in their offspring. It is an option. It's an expensive option, but for those who have given birth to a child with their long QT syndrome, or will continue to with their long QT or hypertrophic cardiomyopathy or whatever, I have no fear. I have no fear of you as a family producing a child who inherited your LQT causative mutation. When we know it's there, tragedy never happens, almost never. When we know it's there, our treatments are incredibly effective, and you can and will live and thrive despite your genetic heart condition. So it's an option for you, but if you're not pursuing that option, please, please, zero guilt when and if you pass it on to your child, because you'll be passing on many amazing genetic attributes, and you may pass on 50-50 chance your disease causative variant. But if you do, and we know it's there, we can treat it well. Barbara out there, shout out to you, Barbara, because I was right. She confirmed it. It was the movie Sliding Doors. So thanks for that one. And there was a great question that popped in through here. Sherry, thanks, Sherry. She's asking, where can we get a 4-year-old genetically tested for LQT3? And then goes on to describe some of the situations and some of the challenges. And like Allison and I were talking about, and Lee even emphasized, genetic testing is easy to obtain. Those who are saying there's impediments aren't trying, to be honest. To say it was hard to obtain circa 2003, sure, I will spot that. Expensive, over $5,000, denied as the rule of thumb. Now, fast forward from then till now, much less expensive, sometimes free, as in really inexpensive, increasingly covered by insurance policies. So bottom line is, if you or a family member has been diagnosed with long QT syndrome, Brugada, CPVT, HCM, and your healthcare team is not getting the genetic test performed, they're not practicing standard of care, pure and simple. It is the standard clinical diagnostic test for any patient out there who's being told you have long QT syndrome. And then when and if the disease causative mutation is found, then variant specific testing is performed on all of the appropriate relatives, so that we could potentially dismiss those who did not get it and watch like a hawk and treat well those who did get it. And Sherry, there's a program from a couple weeks ago. I interviewed the CMO of Invitae, Robert Nussbaum, and that was a great episode. You should look back on it if you That was last week, episode 37. So Invitae, you could get it for basically free through an Invitae Detect mechanism, Ambry Genetics, GeneDx, and all of those three genetic test companies supported our program last week, our virtual International SADS Foundation conference that was to be held in Houston, Texas, got coroned, and so we went virtual with it, and it was amazing last week. Over 400 attendees, and from 30 countries. And so if you missed that, check out that material that will be available on our website or on the SADS YouTube channel. That was rich in material. And so thanks for all of you who joined us for those several hours last week. And I think Michelle is asking a question, a great question, Michelle. When is the new version of the LiveCore CardioMobile going to be available? So full disclosure, I'm one of the inventors of proprietary Mayo Clinic information, knowledge, that is being investigated and studied and incorporated into a LiveCore. That myself, several investigators here at Mayo Clinic and Mayo Clinic. So there is a potential royalty relationship when the QT knowledge solution gets added into their CardioMobile device. Right now, CardioMobile is an FDA approved device for detection of atrial fibrillation, tachycardia, bradycardia, but not yet for a QT meter. That's going to change. It's under review at FDA. There's going to be an exciting paper coming out in the near future about our work and moving QT solution from being stuck getting a 12-lead ECG to a smartphone-enabled mobile solution. So it's going to be a pivot point in QT history, if you will. And so we'll keep you posted. It's that QT solution has not been incorporated into the AliveCore device yet, but it certainly will be in 2021. I think there was another great question. I'm going to scroll up here. Oh, Carrie had a great question. Thanks, Carrie. She's asking if we were only tested for RYR2 9 years ago, should you now be tested for other new genes? I like that question, Carrie, and maybe you can follow up and I'll look on the panel if you ping a response. It kind of depends. So I'm assuming that the reason that gene RYR2 was picked for your family is because the person in your family, the diagnosis of CPVT was given, meaning your relative, your family member, your child, you, whoever it was, the doctor said, you know, I think you have CPVT. And because of that, you then order the best test that covers that diagnosis, CPVT, for which it is the RYR2 gene. And we know that the mutations in the RYR2 gene explain about 70%, 65 to 70% of that disease. And so there's a couple things about it. 9 years ago, so let's say, and I'm assuming, Carrie, thanks for confirming the diagnosis, that back then, 9 years ago, the RYR2 test came back negative. And if that's the case, should you look at other genes? I would say more important than looking at other genes is if the doctors really still think you have CPVT, I would redo the newest generation genetic test, not so much for other genes, but to get a current, better look at the RYR2 gene. That gene was a challenge 9 years ago. 105 translated exons. Difficult to analyze all of them. The genetic test 9 years ago may not have even looked at every one of those 105 exons. So I personally, if I was taking care of you, if I thought your daughter had CPVT and that test from 9 years ago came back negative, I'd say, you know what, let's do it again with the most contemporary genetic test that has better ability to detect a true mutation, if it was truly there and was missed 9 years ago, or to interrogate the entire 105 exons if back then not all 105 were examined. So these were great, and I think it's a great setup for next week. For those of you who will join us next week. Next week is a part 2. It's a return on the highlight reel because Shannon Horrigan, I don't know if you remember that name, but she joined us maybe 6 months ago, I don't remember, about psychology and emotional well-being and resilience and things like that. And so she's coming back to join us next week. I'm looking forward to her and you all joining us for SADS Facebook Live. And on this Friday the 13th, that can be spooky. We all remember the Friday the 13th movies and so forth. And when you see a spike like we're showing you of the crazy number of cases throughout the world and the United States, I know you can feel it in the air how worried and nervous and anxious that people are. And we're being maxed out. And I'd just like to encourage you all and give you a challenge. If maybe you find yourself so distracted with the noise out there and the fear out there and the worry out there, what could you think about doing that maybe is different, that could get you focused on the things above and not on the things of the earth? I'll share with you what I do. For many years now, I walk to work every day. It's about a 10-minute walk. And during that 10 minutes, I just speak during my walk verses that I've memorized. And I do that on the way to work. On the way home from work, I actually look at Instagram and Twitter and things like that. But on the way to work, as I get my day going, I have a collection of verses, about 10 minutes worth, that I just breathe out and I speak out. And it just gets me right, no matter what my previous day was like. And I'll give you one. If you're looking for one to add, or if you've never memorized scripture before, do this one with me. It's Psalms 103, verses 1 through 5. And I'll just leave you with it to encourage you. I say this every morning as my final set of verses for the morning. Bless the Lord, O my soul, and all that is within me. Bless his holy name. Bless the Lord, O my soul, and forget not all his benefits, who forgiveth all thine iniquities, who healeth all thy diseases, who redeemeth thy life from destruction, who crowneth thee with loving kindness and tender mercies, who satisfieth thy mouth with good things, so that thy youth is renewed like the eagles. It's hard to have a bad day when you sort of start it that way. So if you find yourself bombarded in fear and worry and anxiety, and it's paralyzing you, maybe step out from yourself and reach out to words from the Almighty that can kind of change everything. I wish you well. Have a wonderful weekend. Refuse to fear. Be anxious for nothing. So until next week, peace and blessings to you all.